my pleasure to introduce Christine Lee to you all today. Christine is a summer student that has been working with us this summer. She was here last summer as well, and she liked us so much that she decided to come back. So she's going to talk a bit about what she's been working on for her summer project this year. I believe this will be recorded, and so we will post this on our website afterwards if anyone wants to check it out, share it with their friends. You can also see the work that she did last summer on the survey that we did. That's also posted up on our website, so you can go check that out there as well on our research page. So without further ado, I will allow Christine to come up and take the reins.
Okay, can everybody hear me? Okay, awesome. Thank you, Jason. Good afternoon. Thank you so much for being here and for tuning in from Moose Jaw, seems like. As Jason mentioned, I'm Christine. I'm moving up to my second year of pharmacy. And today I'll be giving a brief presentation about the research project that I was working on over the summer. So the project was to see the effect of an educational intervention on reducing the use of urine culture and antibiotic treatment for residents in long-term care home who have asymptomatic bacteriuria. So just starting off with some background information, as most of us are aware of, the urinary tract infection is a bacterial infection in any part of our urinary tract system, so our bladder, urethra, ureters, kidneys, etc. And when a person has a UTI, it's usually accompanied by some pretty specific localizing symptoms like dysuria or pain when urination, increase in frequency, urgency, incontinence, acute back pain or suprapubic pain. And the list goes on, but the main point being that there are usually some localizing symptoms to indicate a UTI. So an extremely common condition in long-term care homes especially, accounting for up to 60% of antibiotics prescribed in the setting. So something that confounds the accurate diagnosis and treatment of a urinary tract infection is this condition called asymptomatic bacteriuria. So as the name suggests, bacteriuria, or the presence of bacteria in the urine, asymptomatic without the resident showing any signs or symptoms of a urinary tract infection. So this happens when the urinary tract system of a resident is colonized by bacteria, but it's not infected by it, hence they don't show the localizing symptoms. And this is problematic for diagnosing a UTI because asymptomatic bacteriuria, like a UTI, can also cause the urine CNS to come back positive. And it really doesn't help that this is also a very prevalent condition in long-term care homes, accounting for up to 50% of elderly population having this condition, and 100% of them if they have a long-term endowment catheter. Okay, so quite a bit of research has gone into the harms and benefits of treating asymptomatic bacteriuria, and pretty much all of them conclude that with the exception of pregnant women and people who are scheduled for urological procedure, treating asymptomatic bacteriuria is not correlated with decreased mortality or morbidity or the prevention of a symptomatic UTI, but it is correlated with recurring infections with more resistant bacteria, so harder to treat, adverse drug reactions like your nausea, vomiting, stomach ache, those antibiotic stuff, and also C. diff infections, which can be quite serious. So all in all, no benefits to come from it, but all the harms, and we shouldn't treat asymptomatic bacteriuria with antibiotics. So based on those research, the guidelines and recommendations all say Infectious Diseases Society of America guidelines shown here and Choosing Wisely Canada, basically to not screen for asymptomatic bacteriuria and not treat it if we find one. So in other words, that urine CNS and antibiotics should only be ordered for residents that show localizing signs and symptoms of a urinary tract infection. So this is the diagnostic criteria that we use for UTI in our QHR. I know it's a pretty small picture, so I don't expect you to read all the lines here, but it basically lays out all the symptoms or the combination of symptoms that is needed for a resident to be a symptomatic UTI patient. And it also outlines some criteria for urine CNS results. So it basically comes down to two things: that residents should show localizing symptoms before sending urine CNS, and that the urine specimen should be non-contaminated, so as in less than 3 organisms should be present, and cause a positive urinalysis and urine CNS result, as in there should be more than 10 to the 8 CFU per liter of bacterial colonization. So that's all the theoretical stuff we have, but the problem that we face is still 2/3 of the residents with asymptomatic bacteriuria is treated with an antibiotic. And this is the type of scenario that they kind of face every day. So here's a resident of a long-term care home, and she's doing all fine and dandy until one day she presents with dark-colored, foul-smelling urine and some confusion. And their family suspects a UTI and strongly suggests some tests to be done. So clinical staff catches a urine specimen, sends it off to the lab, and when that comes back, it comes back positive with E. coli. And the prescriber looks at this, orders macrobid, 100 milligram BID for 1 week to treat her urinary tract infection. So if you look into that scenario, it kind of starts off with the resident having these broad range of symptoms like confusion, some weird urine characteristics, other things like behavioral changes or increased falls also. And these are not the localizing symptoms of a UTI, but in fact, they're the non-specific signs and symptoms that can be caused by quite a number of different things, like dehydration, constipation, medication, and stuff like that. And those symptoms, with a little push from the resident and their families, often leads to a urine CNS to be sent, which then often comes back positive because a lot of people have asymptomatic bacteriuria in long-term care homes. And the problem with these positive urine CNS is that it's really hard to ignore. When we have a positive urine culture in front of us, we tend to deal with it more than just leave it. So that often leads to inappropriate antibiotic use for residents with asymptomatic bacteriuria. So this whole scheme shows that we need to tackle this problem in 2 different spots. Number 1, when we're assessing the patient, if they don't have localizing symptoms, we shouldn't send the urine CNS. And number 2, when that urine CNS comes back, if the resident is asymptomatic, then we shouldn't initiate them on an antibiotic. So to deal with the problem that we have, we were doing some literature review. And I should mention that this study was largely based on a previous local study done by one of our pharmacy residents, where she looked at asymptomatic bacteriuria in acute care setting. So she used an educational intervention, which resulted in decreased rate of treatment of asymptomatic bacteriuria and also the rate of CNS ordered. So we basically took her study method and adapted it to long-term care home for this project. And for long-term care specifically, the study by Zabarsky also did an educational intervention that resulted in sustained reductions in inappropriate treatment and decreased total antimicrobial use. So that's what we did. We did an educational intervention with the research question, can an educational session decrease the number of inappropriate urine CNS and antibiotics for residents with asymptomatic bacteriuria in long-term care home? So there were 3 main phases to the research: the pre-intervention audit, the educational intervention, and the post-intervention audit. And in both of the audit phases, which was 5 weeks in length, all the positive urine cultures from 7 different long-term care sites was sent directly to our office. And I used this information to go to the long-term care site and do a chart audit. And I was mainly looking for right indications for urine CNS and the kind of the nature of the antibiotic order. And then the educational session was provided to all interested clinical staff, so nurses, LPNs, CCAs, and all the other managers and administrative staff who wanted to come. And they were given a 15-minute educational session along with a poster and a pocket card outlining some diagnostic criteria. And then, of course, post-intervention audit to see if that did anything. So here are the results, just starting off with some demographics here. We can see a lot of the residents were female in their mid to late 70s, so quite an elderly population that we're dealing with. And for the bug that was causing the suspected UTI, so asymptomatic bacteriuria or UTI, we had E. coli and Proteus mirabilis, which are 2 very common drugs for UTI. Common bugs for UTI, not drugs. So these are the urine culture usage for pre-intervention audit that happened May to June. So we received 171 total urine cultures. 71 of them were positive, so they were all audited. 9 of them were excluded because they didn't meet study inclusion criteria, as in they were either duplicate entry, scheduled for urological procedure, had alternate site of infection, or required extensive clinical judgment. So 62 remained, and they were all analyzed, and it turned out that 81% of those people had asymptomatic bacteriuria. So in other words, 12 out of the 171 suspected UTI residents actually had a UTI. So quite a low number there, 19%. Then the educational session happened between June to July with 2 main messages of let's assess for localizing symptoms before sending urine culture, and let's not administer antibiotics for residents who are asymptomatic. So we had around 10 to 30% participation of nurses, LPNs, ECAs, etc., which is not quite the number that we wanted, but that's what we had. And same thing with the post-intervention audit that happened June to July. We received 155 total urine cultures. 56 of them were positive, so therefore audited. 6 of them were excluded for the exactly same reason. 50 of them were analyzed, and it turned out that 70% had asymptomatic bacteriuria. So in other words, 15 out of 155 suspected UTI patients actually had a UTI. So we can see the slight increase in the proportion of people who actually had a UTI from 19% pre-intervention to 30% post-intervention there. So going a little deeper into the data that we have, the first goal of this project was to decrease the inappropriate use for antibiotics for residents with asymptomatic bacteriuria. And this goal would be met if residents stopped getting antibiotics for their asymptomatic bacteriuria. So that's exactly what we saw. In pre-intervention, 45 out of 50 residents, so that's 90%, received antibiotics for their asymptomatic bacteriuria, and this number dropped to 62.9% post-intervention, so around the 30% drop there. And when we ran a chi-square analysis on that, it was significant with the p-value of 0.003. And the odds ratio indicated that residents were 5 times more likely to receive antibiotics pre-intervention than post-intervention for their asymptomatic bacteriuria. And these are the site-specific data here. Each of those lines there indicate the long-term care home that was audited, pre to post-intervention, and the y-axis being the percent of patients who actually received antibiotics for the asymptomatic bacteriuria. And we can see that with the exception of one long-term care here who's consistently at 100%, all the rest of it is at a downwards incline there. So which is concurrent with the conclusion. So for the second goal, it was to decrease the inappropriate use of urine culture for residents with suspected UTI. And we would meet this goal if the proportion of residents that show localizing symptoms increase and the total number of urine CNS decrease. As in, the clinical staff would do a more thorough review on the patient and look for those localizing symptoms and not send their urine CNS if they don't find it. So for the assessment of localizing symptoms, we did see an increase from 34% to 44%, so about a 10% increase in residents showing localizing symptoms. But when we look at the site-specific data, we can see that all the lines are kind of going everywhere, up, down, so not really a general trend to be seen. And when we ran a chi-square analysis, it was shown to be statistically insignificant. So we can conclude there that educational intervention was associated with an increase in proportion of residents with localizing symptoms, but that it wasn't statistically significant. So for the total number of urine CNS sent, we saw a decrease from 13.2 urine CNS of 100 beds to 11.9 post-intervention. But when we look at the site-specific data again, not really a general trend. Most of it's going down, kind of, but still all over the place. So we can conclude there that educational intervention was associated with a decrease in the number of urine cultures sent per 100 beds, but probably statistically insignificant again. So all of that put together, the conclusion would be that an educational intervention was correlated with a significant decrease in the inappropriate antibiotic prescription for asymptomatic bacteriuria, but that it wasn't correlated with decreased CNS uses. So just to touch on the impact or the possible significance of this project, the main one would be the improved patient outcomes. So they don't have to swallow 3 pills unnecessarily a day. So they don't have to suffer possibly from antibiotic resistance or adverse reactions, et cetera, et cetera. But aside from that, there are some cost benefits associated with this. So if you look at the pre-intervention, we used around $2,400 for the treatment and diagnosis of asymptomatic bacteriuria. And this number dropped down to $1,600 post-intervention. So that's around an $800 save and a 33.4% decrease for the total cost. And I should mention that the cost for antibiotics actually dropped like 60%. So quite a significant decrease there. So that's in a year, that's $4,000 saved just in the 7 long-term care sites for doing what we were supposed to do. So just imagine that like going out to all of the RQHR, there'll be quite a significant save there. So to mention strength and limitations of the study, the strength is that we conducted it in multiple facilities, so 7 different long-term care sites in Regina. We did collect a lot of qualitative information, like the indication piece, which complemented our quantitative information well. And the inclusion of all interested clinical staff in educational sessions. So, of course, the nurses, but also LPN, CCAs, who seems to have a bigger role in noticing the residents' changes in long-term care home. They were all on the same page with diagnostic criteria. For limitations, most of them came from the fact that this was a 10-week summer research. So that led to the small sample size, which the results are hard to extrapolate. There could have been multiple confounding factors. And one thing I do want to mention is the catheter part. So one of the symptoms for the catheterized resident that indicates the UTI is a change in mental status. And that seems like a pretty simple thing, but it also goes into the sub-criteria that it needs to be acute onset, fluctuating, they need to show inattention, et cetera, et cetera. And most often on the patient charts, it wasn't charted that specifically. So it just said a decrease in mental status rather than like a 3-point decrease in this criteria. So we kind of gave them the benefit of the doubt of, okay, if you said mental status, then we gave it to you. So that might have caused the overestimation of catheterized residents having specific symptoms. Some vacation time. So the post-intervention audits were more in the summer vacation time, and that might be why the urine culture dropped a bit. There was also IPAC education that went on at the same time about the same matter, and different resident populations in long-term care homes. We did also have lack of involvement from key healthcare professionals like doctors, obviously, and limited staff involvement with maximum 30% of people participating in the educational session. So for some future directions here, involvement from other healthcare professionals would be really, really nice. And just a repeat of the study over a longer period of time so that most of those confounding factors might not be of matter. And as an antimicrobial stewardship program, we are sending out some site-specific data and feedback and hoping to collaborate with those long-term care sites on finding a sustainable method to carry on this initiative. And also providing some resident and family education because we've been hearing from nurses and LPNs that patients and family have a big role in driving this inappropriate use. So with that, thank you, Antimicrobial Stewardship Program, for letting me do this. The Infection Prevention and Control Team, Long-Term Care Directors of Care and Staff, and Michelle and Ellie for helping me analyze the data.